Ladies and gentlemen, welcome to our continuing medical education session on pharmacological therapy in patients with acute coronary syndromes. We are honored to have you all here today to discuss and learn about the latest advancements and best practices in this critical area of cardiology. To commence our session, it is my pleasure to introduce our esteemed chairperson for today. He is the Managing Director and Head of Pediatrics Department at Bahrain Specialist Hospital. He is also a distinguished pediatrician and infectious disease consultant with a wealth of experience and dedication to medical excellence. Please join me in welcoming Dr. Kasim Ardati to give the welcome address.
مساء الخير, good evening, وكل عام وأنتم بخير. I'm very glad to be with you today to see old friends and to meet actually new friends. And it is very nice to see you all here and to welcome you. And I think that this session reflects the commitment of Bahrain Specialist Hospital to continuing education. We are very proud of our cardiology team, and we are especially proud of our cardiology consultant from far away, from Chicago, who is with us today. And I hope that you will enjoy this session, and I'm very much happy to see you all. Thank you for your attendance, and see you again, inshallah, on other occasions. Thank you.
Thank you, Dr. Kasim. Now, today's program is packed with insightful presentations from leading experts in the field. But before we start with the session, let me introduce our moderator for today, Dr. Mahmoud Saraya. He is a consultant cardiologist at Al-Kindi Hospital. He is also an associate professor at Cairo University, Egypt. He holds a PhD in cardiovascular medicine and has expertise in interventional and general cardiology. He is an active member of the European and Egyptian Societies of Cardiology. With his extensive knowledge and experience in cardiology, he will guide us through the session and facilitate our discussion. Please help me welcome once again Dr. Mahmoud Saraya. Now it's my pleasure to introduce our distinguished panelists for today's session. Our first panelist is Dr. Rekha Matta. She recently joined as the consultant cardiothoracic surgeon at BSH Apollo Heart Center. She has 28 years of experience post-MCH in CTVS and has independently performed more than 10,000 cardiothoracic and vascular surgeries in both adult and pediatric patients. She has several years of experience in university hospitals and has trained many residents. She is a life member of the Indian Association of Cardiothoracic Surgeons in the European Association of Cardiothoracic Surgeons. Once again, Dr. Rekha Matta. Our second panelist is Dr. Prashant Prabhaker. He is a consultant cardiologist with 16 years of experience in adult cardiology. He has trained across many government and private hospitals in India and abroad in clinical and preventive cardiology. He has a keen interest in 2D and 3D echocardiography, transesophageal echocardiography, strain rate imaging, and non-invasive coronary angiography. He is also an active member of the European Association of Cardiovascular Imaging. Please help me welcome Dr. Prashant Prabhaker. Now, to begin with our session, let me introduce our first speaker. Today, we have three distinguished speakers who will be sharing their expertise on various topics related to pharmacological therapy in acute coronary syndrome. So let's begin with our first speaker. He will be speaking on anticoagulants in acute coronary syndrome. He is an associate professor of clinical medicine at the University of Illinois at Chicago in the Department of Cardiology, and serves as an interventional cardiologist. In addition to his clinical duties, he He is an Assistant Dean for Perioperative and Inpatient Clinical Affairs at the University of Illinois Chicago College of Medicine, and the Director of Cardiac Catheterization Laboratory at the Jesse Brown VA Hospital. He completed his training at the University of Michigan and Duke University, and is a 3-time recipient of the Clifford Pills Faculty of the Year Award from the University of Illinois Chicago, Department of Medicine. Now please help me welcome our first speaker, Dr. Amer Ardati.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for that warm welcome. Bismillahir Rahmanir Rahim. It's a real privilege and an honor to be back in Bahrain, to be amongst friends and family, and to join this esteemed audience in discussing a topic that's near and dear to me, acute coronary syndrome. And along with my colleagues, we're going to review the pharmacological management of this common condition, and I'll be focusing on antithrombotics in the acute coronary syndrome. My objectives for today are to discuss the role of anticoagulants in ACS and to understand the differences between the 3 drugs that are most commonly used for the management of the acute coronary syndrome. And critically, I'd like you to understand how to manage patients who require systemic anticoagulation after revascularization. I want to start with a case. This is a 60-year-old male who came to me actually just a couple of weeks ago with sudden onset of left-sided chest pain and shortness of breath. His EKG, as you see here, shows sinus tachycardia with anterior ST elevation. And as I was consenting this patient, he went into VT, requiring CPR and resuscitation and intubation, after which the patient was taken to the cardiac catheterization lab. This is his angiogram here, and to orient you, this is a cranial picture showing the catheter engaged from the right radial artery, and the coronary is filling, and the LAD ends right after the first major septal perforator. And for those of you with keen eyes and maybe experience with angiography, you may notice the severe calcification of the LAD. Here is more of the same, showing this mid-occlusion in the LAD, and a picture of the right coronary artery that is dominant, that has intermediate disease throughout, and most importantly, you can now very clearly see the calcification in the left anterior descending artery. So why do bad things happen to good coronary arteries? This patient's running around, living his life, doing well. This particular person was thin and healthy and highly active and had never had symptoms before. And if we go back to our days of pathology from our preclinical years, we remember that atherosclerosis is a process that begins early in life. And in fact, it's a process that begins typically in the teens and 20s. The plaque forms in the arterial system, and the plaque develops not too different from a pimple that a teenager may have on their face. This highly inflammatory milieu of plaque develops and continuously is in the process of propagation, rupture, thrombosis, and lysis. And most people go through their whole lives without having a coronary event, even though these plaques are forming and expanding throughout life. So what happens to the plaque that's unstable? Well, this thin-capped fibroatheroma has its day, and the pimple ruptures, and this huge pool of cholesterol and thrombogenic inflammatory material becomes exposed to the bloodstream, and platelets adhere and become activated, and the vessel thromboses, and if it's completely occluded, that's what causes an ST elevation amount. And if there's only partial obstruction of the culprit vessel, it's what we call a non-ST elevation acute coronary syndrome. So looking more carefully at this, we know that the activation coagulation cascade follows the initial insult of platelet adhesion and activation. It's this critical point of platelets adhering and activating and development of red thrombus that is the nidus for complete occlusion of the vessel. And what I want to draw your attention to is that there are critical components of the coagulation cascade that are interacted with by the anticoagulates that we use in clinical practice. I'll start with unfractionated heparin that is primarily an antithrombin 3 activator and also attacks 10A. Low molecular weight heparin, which is a subset of all the heparin that we use, is primarily an anti-10A agent with minimal antithrombin activity. On the other hand, bivalrudin, which is a very attractive agent for the management of the acute coronary syndrome, is a direct thrombin inhibitor and has some benefits and potentially some disadvantages in clinical practice. With all of these agents and with all of our management of anticoagulation in the acute coronary syndrome, it is a continuous balancing act of trying to choose agents that prevent ischemia, that prevent clot propagation, that prevent equipment thrombosis, that prevent persistent thrombus formation on the plaque, and most importantly, avoid acute stent thrombosis. However, our agents cannot be so potent that they allow for access and non-access bleeding that can be highly deleterious to our patients who are in a critical point in their clinical care. Let's talk about heparin. Heparin is an agent that we have decades and decades of experience with. It potentiates antithrombin and inhibits 10A. The delivery is weight-based, it's IV given, and it's fast-acting and incredibly easy to monitor in the cardiac catheterization lab and on the ward. When we use this agent, we target an ACT goal, an activated clotting time goal, of 250 to 300 seconds if we're not using a TB3A agent. One of the advantages of heparin is that it's immediately reversible with protamine, and that is readily available in most hospitals and cardiac cath labs. There are some limitations, though. Heparin does not bind to clot-bound thrombin. So the clot that is already there in the coronary artery does not get engaged with this antithrombotic agent. It prevents propagation of the thrombin, but the old clot that's there is not penetrated by this agent. More importantly, at least in my perspective, as somebody who's doing primary PCI, is the variability of the dose effect and the very narrow therapeutic window of this agent. It's not uncommon that we'll give a certain dose in the cath lab and check the ACT and not be therapeutic, and you're waiting to recheck and recheck and recheck, and then next thing you know, you're way over the limit, and you put yourself at risk for injuring the patient. One critical distinction of heparin, especially to distinguish it from bivalrudin, is that heparin actually potentiates platelet activation, and this is a critical difference of this agent, and may be one of the major reasons why there is such a synergy in the use of heparin with 2B3 agents or preloading P2Y12 inhibitors in patients who you primarily use heparin with for the management of primary PCI. And very importantly, for those of you that are managing patients on the ward who receive heparin, is the incidence of heparin-induced thrombocytopenia is not negligible at 0.5%. And as you all know from managing these patients, this is quite a treacherous disorder to deal with and puts you in a very difficult position of managing patients who are acutely at risk for thrombotic events, but also now highly at risk for bleeding complications. Enoxaparin, low molecular weight heparin, particularly an enoxaparin agent that we primarily use in the United States, is primarily an anti-10A agent with very limited antithrombin activity. This drug can be delivered subcutaneously or IV. The subcutaneous delivery of this drug potentiates the ability to give this drug in hospitals that don't have the capability to give IV pumps continuously and don't have the capability to maintain continuous measurement of PTT on the ward. One important distinction between low molecular weight heparin and heparin itself is that it's only partially reversible with protamine. And one must remember that this medication is renally excreted, and thus dosing changes need to be taken into consideration in those patients with advanced kidney dysfunction. One other area of concern, especially in our enlarging patient population, is that extreme body weight is controversial for how to dose the agent. And while dosing is recommended at actual body weight, care must be taken at the very extremes of weight. One advantage of this drug is that it has a very long half-life, that it's predictable. However, with the limited reversibility of this agent, this can be problematic when procedural bleeding complications occur. And unlike heparin, the risk of hit, while persistent, is much lower with enoxaparin. Some important differences between heparin and low molecular weight heparin are outlined here in this table, and you can review it at your convenience here. And this summarizes a lot of the things that I talked about in the last few minutes. Unlike heparin and low molecular weight heparin, bivalrudin is a direct thrombin inhibitor that attaches to clot-bound thrombin. The delivery of the agent is weight-based and IV, and we only check an activated clotting time to confirm the activity of the drug, but not to guide dosing. The dosing is weight-based and standard for all patients, with some adjustments made for renal dysfunction. There is no antidote or reversal agent for this medication. However, the short life is incredibly short, and the treatment for any bleeding complications is simply to stop the infusion. One of the critical limitations with this drug is that in the early clinical trials of bivalirudin for acute coronary syndrome is that there was a clear positive signal for acute stent thrombosis. And I'll talk a little bit about where the data has developed, particularly in relation to that concern for this medication. For me, this is the important slide of this talk, perhaps, that compares heparin and heparin-based agents with direct thrombin inhibitors. Again, one major distinction in the mechanism of action is the difference between the two agents, in that bivalirudin is a direct thrombin inhibitor that attaches to clot-bound thrombin. There is no activation of platelets with bivalirudin, and it is a predictable anticoagulant, and there is no incidence of thrombocytopenia with this agent. This is a slide, again, for your reference. I don't mean for you to read all of this, but the dosing is pretty standard and agreed upon. One critical thing I would mention, and I didn't mention it in the list of other anticoagulants, is that of fondaparinux. This is an agent that I have no clinical use for in my practice, because one of the critical problems with fondaparinux is that there is an increased risk of catheter thrombosis with this medication. So if a patient with acute coronary syndrome is treated with fondaparinux on the ward prior to arrival to the cath lab, they require a second anticoagulant agent in their management. So the leading narrative for comparing low molecular weight heparin to unfractionated heparin is that there's essentially no big difference in outcomes between the drugs. So then you may be asking yourself, well, why would I use this drug that I can't measure the low molecular weight heparin? You can't measure an acute activated clotting time, and you have to remember when it was dosed and how much was dosed and how many hours have passed. Well, the truth is, when we take a closer look at the data, that with low molecular weight heparin in acute coronary syndrome, there are less ischemic events, there is less clinical bleeding, and many of the advantages that are observed are seen in STEMI trials in our most vulnerable patients. And in fact, there is improved safety and efficacy with the IV dosing of low molecular weighting. However, one thing to keep in mind that is important, that is critically important, is that in multiple clinical trials, this observation has been made time and time again, that if a patient is started on low molecular weight heparin for management of their coronary syndrome, and for whatever reason you decide to switch to heparin, bleeding rates increase, and the same is true the other way around. If you start with heparin and switch to low molecular weight heparin, you set the patient up for an increased risk of bleeding complications. How about bivalirudin versus heparin? Well, these are from the early clinical trials that showed essentially clinical equivalence between the two medications, between the two strategies, however, with an increased signal for acute thrombosis. And this, for the most part, and between the cost of bivalirudin being higher than heparin and the concern about this complication, ended bivalirudin's use in STEMI for a majority of practices in the United States. That being said, there's been a resurgence in interest in this drug, particularly with the outcome of two clinical trials recently. One, the Validate Sweetheart. This is a clinical trial, open-label clinical trial of unfractionated heparin and bivalirudin in all ACS comers in a 90% radial practice, with an insistence of continuing the bivalirudin infusion for 4 hours after the completion of the PCI. And in this clinical study, it showed that there was no difference in outcomes between the two. More interestingly, in the BRIGHT trial, this is a randomized clinical trial from China, where 93%, radial use and an insistence in the protocol for 4 hours of infusion of bivalirudin after completion of the PCI showed an improvement in mortality and in bleeding with the use of a bivalirudin-based strategy. And I think that the critical change that was made in this clinical trial compared to the earlier bivalirudin trials is the insistence on a post-infusion dosing of bivalirudin in order to mitigate the stent thrombosis events and to allow for oral antiplatelets to take an effect and to avoid acute stent thrombosis. So what's the bottom line? For me, in my clinical practice, unfractionated heparin remains the default choice. It is convenient, it's easy to monitor, it's easy to reverse, it is cost effective, and I understand what it does very clearly, and I don't have to continue an infusion after the case. That being said, I think there are major advantages to both low molecular weight heparin and bivalirudin that I anticipate our clinical practice will evolve in the coming years as we begin to understand that these agents have some critical advantages. I did want to spend a little bit of time talking about anticoagulation after PCI. So, patient comes in with acute coronary syndrome, you're managing them acutely. Do they need anticoagulation after revascularization? And the answer is, for most patients, no. Patients who do not have an underlying indication for anticoagulation after revascularization do not require continuation of the anticoagulant. They do require their dual antiplatelet therapy. That being said, there are many patients who come into the cath lab with an underlying indication for anticoagulation, like atrial fibrillation, mechanical heart valve, pulmonary embolism. And in these patients, it's advisable that they not be discharged on their anticoagulant and dual antiplatelet therapy. And the contemporary recommendations suggest that for most patients, that they be discharged on their anticoagulant and a single antiplatelet agent, usually a P2Y12 inhibitor, a newer generation P2Y12 inhibitor like ticagrelor or prasugrel, and not on aspirin. For whatever reason, if a patient is thought to be at very high thrombotic risk, bifurcation, left main stent, and they're at low bleeding risk, one can consider discharging on aspirin, P2Y12 inhibitor, and their anticoagulant, and then stopping that aspirin 1 month after. But for 95% of patients, our strategy is to discharge on single antiplatelet therapy and anticoagulation because the bleeding risks are not insubstantial. In fact, on triple therapy, dual antiplatelet therapy and anticoagulation, the risk of major bleeding is nearly 20%. 1 in 5 of your patients will have a major bleeding event if you decide on that strategy. So we'll go back to our patient here. So this is our patient after angioplasty. We took a BMW wire, did a 2.0 balloon angioplasty and opened the vessel. And looks like somebody's playing with my slides. Why don't you let them be and I'll take care of them from my end. You can let it be, that's fine, I have it. So following following balloon angioplasty, we did notice that the severe calcification may limit stent expansion, so we did an intravascular ultrasound. Intravascular ultrasound could not pass initially, so we had to do intravascular lithotripsy of the vessel. And as this intravascular ultrasound comes down, you're going to actually see the breaks in the calcium where the lithotripsy device delivered energy to break apart the calcium. You see that here at 7 o'clock, 4 o'clock, and at noon, and you're going to see it a little bit later in the same spots. So that's the way we deal with the calcium in the acute coronary syndrome instead of using atherectomy. Following that, we put in a 3048 drug-eluting stent. The patient had been intubated after his VT code, and we gave him ticagrelor. We had given him ticagrelor in addition to heparin during the procedure, and he was discharged on post-op day 3 on aspirin and ticagrelor and did very well. In my opinion, anticoagulation is a cornerstone of the management of the acute coronary syndrome. There are many therapeutic choices, and at the end of the day, you need to balance the risk of ischemic events versus bleeding. In our current practice, heparin is the default choice. However, data do suggest some advantages for enoxaparin and bivalirudin. And then post-intervention anticoagulation should be rare, and if patients are anticoagulated after ACS, you should consider discharging on a single antiplatelet therapy in addition to their oral anticoagulant. I thank you for your time, and I'm happy to take questions either now or with the rest of the program.
Thank you so much. almost covered all the issues regarding the anticoagulation. Now I would like to open the floor for the audience for any questions regarding this topic. If you have any questions, I see this topic is very challenging, and many people, we need patients coming to the emergency department on anticoagulation, having acute coronary, just like that, because of the lack of the efficacy of different anticoagulation. And at that time, we sometimes struggle whether what to give them, when to give them the medicine, specifically the timing before and after the job. My first question is, in patients who are taking any kind of novel oral anticoagulation, the old guidelines are usually focusing on what to do post-PCR. They are concerned much about the bleeding issues, specifically that they used to give the anticoagulation for 3 months, nowadays for 1 month or even up to 1 week for anticoagulation association with dual antiplatelets, especially in cases with large stem burden and the way the risk of bleeding against that very important or risky. My concern is before the admission of the patient to the angiogram. If the patient is on anticoagulation, what do you recommend the doses and the anticoagulant?
That's a great question. I think one of the key things that has changed in our practice in the United States, and I think you here in Bahrain and in Europe have been way ahead of us, is the adaptation of radial access for the management of acute coronary syndrome. So like you, we have a very large patient population. Obesity is a major problem, and going femoral in somebody who's on oral anticoagulation is no fun when the anticoagulants are active and you set yourself up for post-procedural bleeding. Our center has made an effort, and we're 95% radial, and that has given us a lot of comfort. Now, with regards to choice of agents, I think it's incumbent, if the patient is fully anticoagulated on an oral agent, to use a reversible IV agent. So heparin is my go-to agent for those patients, because I know what my anticoagulant effect is. I know I can reverse it if I have a complication, and if I'm radial, I can avoid at least access site bleeding very easily. Yeah, good question. And we go to the lab immediately. We don't wait. If the patient needs to go to the lab, if it's a STEMI, they go to the lab immediately. If it's a high-risk non-STEMI, they go to the lab immediately. If they're a low-risk asymptomatic non-STEMI, we may sit tight, but it doesn't really matter.
You advise the patient to go directly to the cath lab without any delay, even if he's anticoagulated, so that it's very important point and very important.
Absolutely. If there is a clinical indication to go directly to the cath lab, they go to the cath lab, regardless of the status of their anticoagulation.
Another question is, some people, they come with non-anesthesia integration of cardiac infarction, and for the time they prepare for the angiography, they can be kept on anticoagulation. And meanwhile, they start having ongoing chest pain or complicating during the period of observation they preparing for the anticoagulation. Because we all know that these people can go either immediate for immediate angiography or delayed angiography.
Correct.
According to their condition. The problem that I face is that when the patient is on anticoagulation like medicine or like enoxaparin, sometimes they omit the dose of the fractionated heparin in the cath lab. I need your guidance regarding this, when to give the heparin and not to give the heparin while having recent injection of subcutaneous or intravenous.
Great. So this is where every time this happens, because we're a primarily heparin-based hospital, but we often get transfers from smaller hospitals that cannot manage IV heparin. IV heparin is a big deal for the nurses. It's a lot of work. It's a continuous infusion. They have to check PTTs every few hours, and enoxaparin saves a lot of time and effort and money, and a lot of hospitals will use it, and I think there are advantages for that strategy. But the same question comes up, is what do you do in the cath lab, and do you trust the medical record that comes with the patient? How many doses did the patient get? Did they get a correct weight-based dose? And how many hours ago was that dose? And the key number is 8 hours. So if the patient had a proper weight-based dose within 8 hours, you're within your rights to continue the PCI without additional anticoagulants. anticoagulation. If there have been more than 8 hours provided, the dose, I believe, is 0.3 milligrams per kilograms IV to be given. And if the patient has had nothing and you want to use enoxaparin, the dose is 0.5 milligrams per kilogram IV as a single time dose to do the procedure. And I think this is one of the areas where good communication with your referring center and with your ward is so important, because we're really relying on that information to make the right decision on how to manage these patients. And as I showed in the other clinical trial data, that if you double up with heparin, you significantly increase the risk of bleeding. So you have to be sure. All right. Well,
Any question from?
Fantastic case there. So very early transplant lesion and very good result with the report. My question is, how often do you use cannula IV-based?
yeah, great question. You know, especially in a patient like this that's intubated and I don't know when they're going to get their oral agents, I'll pull the trigger on using Cangrelor up front, because, you know, I can't guarantee is the patient going to get their ticagrelor or prasugrel right away? Is it going to be 5 minutes before they get their OG tube? Is it going to be 5 hours? Is the nurse going to forget? You know, Cangrelor at least is under my control, and I can do it up front. So I usually reserve the use of Cangrelor for those patients where I worry about them taking an oral agent up front and quickly. That's my strategy.
Just as a ticagrelor.
Yeah, I mean, you could do either. You can give ticagrelor right away while they're on the Cangrelor infusion, or you wait for the Cangrelor infusion to complete, and then you immediately give a loading dose of clopidogrel or prasugrel.
Dr. Amer, thank you for answering the question. My question is, how often do you use viral as anticoagulant? Very question. And how often, in one case at least, we saw there was catheter thrombosis. How often is the risk of catheter thrombosis?
Yeah.
Or do you supplement with heparin when you
Great question. So, you know, when I was in training, bivalirudin Horizon trial had just come out, and one of the major advantages of bivalirudin in the Horizon trial was a decrease in bleeding events. Now, you have to remember that was in the era of a standard of therapy of heparin plus 2B3A and a practice of primarily femoral access in the United States. So bleeding was very, very common and was quite treacherous. So bivalirudin was very attractive in that it reduced bleeding events. And as my practice changed to become more radial-based, and as the data for bivalirudin, especially with the concern for stent thrombosis, became more concerning, we shifted our practice to heparin. So in my contemporary practice, I limit the use of bivalirudin to those patients who have HIT, who are not candidates for the use of heparin, and that's about it. That's really the only patient population. I can think of maybe 2 cases in the last 5 years. One was a TAVR just a few weeks ago. He had HIT and we had to anticoagulate. And the other one was an ACS patient, and that's really it. It's all heparin for our lab at least.
Thank you for a very nice question for you. Is you have a patient who walks into the emergency room with acute coronary syndrome who's recently had cerebrovascular event, or peritoneal for surgery, or recently had a GIP? Okay? What do you do with these people?
I call you. I call you and I say, what should I do? So unfortunately, you know, our center is a big neurosurgery center, and we have a lot of patients who come in with intracranial events, and it's a very difficult conversation, right? So it all goes back to the patient and comparative risk. If the patient has a non-ST elevation event and they are not hemodynamically unstable, LV function is fine, EKG is fine, hemodynamics are okay, we'd probably err on the side of being conservative. On the other hand, if the patient has shock, has ST elevation, has persistent discomfort, and the bleeding risks are acceptable, we'll go to the lab and treat, but it's a very difficult situation. GI bleed, not to discount how treacherous a GI bleed can be, is, you can always give blood and all bleeding eventually stops, and it's not a contained space like the brain or the spine, and you'll often get away with it. But the neurosurgical patients are definitely very challenging.
How often do you need GI bleeding in your cath lab? What statistics do you tell us?
I never get it. We're a very safe cath lab. No, I mean, we see it all the time. Thankfully, we don't see it in the lab on the table. It's usually in the ICU a few hours later. And our challenge is actually with our GI colleagues who are hesitant to engage with our patients soon after an event. And it's just a matter of building relationships with your consultants and making sure that you trust each other, and to make them understand that the cardiovascular issues after revascularization are largely controlled, and if there's bleeding, it needs to be dealt with. Yeah. All right. Okay, well, thank you so much.
Thank you, Dr. Amer. Now we move to the next session. Okay, but so we can do the next session.
Thank you, Dr. Amer, for that insightful and comprehensive presentation. Now, moving on to the second speaker, he will be discussing on antiplatelet therapy in patients with acute coronary syndrome. He is an interventional cardiologist with more than 15 years of experience in the field of cardiology and over 6,000 successful interventional procedures. He is a life member of the Cardiological Society of India and a member of the American and European Cardiac Societies. He is currently working as a consultant cardiologist at BSH Apollo Heart Center. Please help me welcome our second speaker, Dr. Shaikh Swalehin Bux.
Thank you, Leslie, for the introduction. This one? Yeah, thank you. So after such an excellent presentation by Dr. Amer, it becomes difficult to hold your attention, but I will try my level best, inshallah. Good evening, ladies and gentlemen. Thank you for joining us this evening for this CME on acute coronary syndrome. As you know, acute coronary syndrome is a very common clinical condition that all of us face, and it is associated with very high morbidity and mortality. Therefore, as clinicians, it is our responsibility to take care of such patients to reduce the burden of morbidity and mortality. As you know, acute coronary syndrome is a thrombotic event, and it is triggered by an acute plaque event leading to platelet aggregation, adhesion, activation, and aggregation. So this acute plaque event is mostly due to acute plaque rupture, or it could be due to an acute plaque erosion. So this is the basic pathophysiology under leading to acute coronary syndrome. So antiplatelets like anticoagulant is very important for management of acute coronary syndrome. In fact, they form the heart of the management of acute coronary syndrome. Anticoagulant, as Dr. Amer presented, is important in the initial phase of management of acute coronary syndrome, whereas antiplatelet is important in both acute and chronic phase of management. Because anticoagulant, what it does is it prevents thrombus propagation, whereas antiplatelets, what they do is they prevent the thrombus formation. As you know, when there is an acute plaque event leading to initiation of thrombus, at the heart of all this interplay of thrombus formation is the platelet, which plays a central role in formation of thrombus. Therefore, your target is to block this pathogenesis of thrombus formation. Therefore, antiplatelets plays very important role. A bunch of platelet receptors, as you'd recognize in this carton, plays very important role in the interplay of interaction and leading to platelet adhesion, activation, and aggregation. Starting with the group of platelet receptors, they are called GP receptors, and these receptors lead to first set of activation, first set of interaction, that is glycoprotein 1B and von Willebrand factor. This leads to a chain reaction and the platelets go crazy and all these interactions, complex interactions takes place. It can be summarized in three categories. One is the thromboxane-mediated interactions, another is the ADP-mediated interactions, and the third is the thrombin-mediated interactions. Therefore, they are the legitimate targets by all these antiplatelet agents that we currently use, and also they are the targets of future antiplatelet agents in development. So, as you can notice here, after the platelet adhesion, there occurs platelet activation leading to formation of platelet aggregations. Okay, so most important in this interplay is two important pathways that are central to our antiplatelet drugs, that is the thromboxane-mediated interactions and the ADP-mediated pathways. The drugs which we currently use as an antiplatelet include aspirin, clopidogrel, prasugrel, ticagrelor, cangrelor, and GP2B3 agents. I would like to go back to this carton to explain more about these drugs. The thromboxane-mediated pathways, as you can see, that leads to the platelet aggregation, and that is the target by aspirin. When it comes to platelet, the other receptors, the most famous and most important receptor among them is the P2Y12 receptor, which is the target of antiplatelets like ticagrelor and cangrelor. Then our commonest antiplatelet agent like clopidogrel and prasugrel. The difference between these two groups of drug is that clopidogrel and prasugrel, they are prodrugs and they need hepatic metabolism to be converted into active metabolites, whereas ticagrelor and cangrelor and the newer agent silatogrel, they are active agents. They directly bind to these P2Y12 receptors to activate this sequence of events. Therefore, it is important to know the difference, which will make us understand that clopidogrel is a slow-acting drug, whereas prasugrel, ticagrelor are fast-acting drugs. I know most of you are aware of all these commonly used antiplatelet agents, so I will quickly take you through some of the slides mentioning the features of these antiplatelets. Aspirin is one of the commonest and oldest antiplatelet agent that is in use, known to humankind since ages, but its antiplatelet action is known recently since maybe 4 to 5 decades. Aspirin, as you know, is a COX-1 inhibitor. It blocks the formation of thromboxane by blocking the formation of arachidonic acid to prostaglandin H2, and thromboxane is responsible for platelet aggregation and vasoconstriction. Therefore, blocking this pathway leads to the inhibition of thromboxane-mediated platelet aggregation. Now, aspirin, its efficacy has been proven by several trials, starting with second international study on infarct survival, that is ICIS-2 trial, which proved the efficacy of aspirin. Following which there were several trials which were conducted which showed the efficacy of aspirin, and finally there was a meta-analysis conducted by ATT, anti-thrombin trialist group. On this meta-analysis also they showed aspirin decreased the primary endpoint of major vascular events, coronary events, strokes, although it increased slightly bleeding, but that was acceptable. But the problem with the aspirin is that there is about 30 to 40% incidence of aspirin resistance in general population, mostly mediated by alternative pathway activation, because aspirin, if you remember, it's a ADP pathway blocker, and when there is platelet activation, there are multiple pathways or channels of activation that take place, and aspirin only blocks one of the pathways. Therefore, because of these multiple other pathways remain open to activation, they lead to platelet, being non-responsive to aspirin in certain situations like acute coronary syndrome. Therefore, aspirin alone is not enough in a high-stakes situations like acute coronary syndrome, and we needed more stronger and more reliable antiplatelet agents, which was found in the form of, most famously, a group of antiplatelet agents which are called P2Y12 receptor antagonists. The mechanism of action of these drugs is that, as you remember, the P2Y12 receptor is the receptor which gets activated when ADP binds to this receptor, and following this, what it does is it does a conformational change in another receptor called GP2B3A receptor, which is also target of some of the antiplatelet drugs that we'll be discussing, and this conformational change leads to aggregation of the platelets, and therefore P2Y12 receptors are important targets of some of the antiplatelet agents that we use. And of this group of drugs, clopidogrel is the second generation P2Y12 receptor inhibitors, whose efficacy has been proven in several trials, starting in different situations, whether acute coronary syndrome or non-acute situations, in STEMI, in non-STEMI, in several situations, clopidogrel's efficacy has been proven when it was compared with aspirin. So this is one trial called CAPRI, where clopidogrel was compared with aspirin in a group of patients presenting with chronic atherosclerotic vascular disease, including CVMI and peripheral artery disease. Standard dose of aspirin was 325 and clopidogrel was 75, was given for 2 years, which showed clopidogrel reduced the primary events of death, MI, and stroke by 8.7%. Subsequently, several other trials like CURE in non-ST-ACS, then CREDO compared longer duration of dual antiplatelet to 1 week of dual antiplatelet, then COMET trial, then came CLARITY. All these trials, they proved one thing. One is clopidogrel is superior to aspirin in terms of antiplatelet action. Second, clopidogrel in addition to aspirin is superior to clopidogrel or aspirin alone. But like aspirin, clopidogrel also suffers from interpersonal variability of antiplatelet action, which is very important to remember, because like aspirin, there will be some group of patients when on clopidogrel, if you test their platelet function, you will find that some of them will have high platelet reactivity, that is called on-treatment HPR. So this is found in about 30% cases, and one of the reasons for this high on-treatment HPR is genetic polymorphism. As you remember, clopidogrel is a prodrug. It requires hepatic metabolism to be converted into active drug. And when it requires hepatic metabolism, some of these enzymes can be, due to their genetic polymorphism, can be fast or slow acting. The enzymes, the people where the hepatic enzymes are slow metabolizers or slowly acting, there is chance of clopidogrel non-reactivity. Therefore, giving clopidogrel to such patients will expose them to high risk of ischemia and ischemic events. Therefore, there was need to find more reliable, stronger, more faster acting drugs, which was found in the form of two important drugs that was developed back to back. One of them is prasugrel, which is similar to clopidogrel, is from the same group as clopidogrel, and it's also a prodrug, but its action is faster than clopidogrel because it is metabolized more efficiently compared to clopidogrel. Prasugrel was compared with clopidogrel in a trial called Triton TIMI 38, which tried to assess, in 13,000 plus of patients, high risk presenting with high risk acute coronary syndrome going for PCI. So, these patients were randomized to prasugrel versus clopidogrel. And standard dose of clopidogrel was 300 loading followed by 75 maintenance, and prasugrel was 60 followed by 10. They were followed by 12 months median, and they found that prasugrel was superior to clopidogrel in terms of primary composite events. Primary composite events including death, MI, revascularization, but there was higher risk of TIMI major bleeding, and there was a higher incidence of non-CABG related bleeding. However, when we combined these two ischemic and safety and efficacy endpoints, we found that the net clinical benefit favored prasugrel. Now, there was another drug, prasugrel was, in addition to PCI situations, prasugrel also was tried in non-PCI situation in medically managed patients. We wanted to know whether prasugrel is still beneficial in patients who are not managed with PCI. That was the trial called Trilogy ACS trial, where non-ST ACS patients were randomized to prasugrel versus clopidogrel with the standard dose. However, we found no benefit of prasugrel in group of patients being managed medically without PCI. Then the second drug that was developed with respect to after clopidogrel resistance, the second drug is called ticagrelor. It is a novel antiplatelet. The difference between prasugrel and ticagrelor is that it is directly acting, it is not a prodrug, doesn't require hepatic metabolism, and it is faster acting. Another important point to note about ticagrelor is it binds to the receptor reversibly. Therefore, it has faster onset and offset kinetics. Ticagrelor was compared with clopidogrel in a trial called Plato, where clopidogrel was given standard dose and ticagrelor was given 180 milligram loading followed by 90 milligram twice daily for 12 months, which showed there is decrease in primary endpoints with almost 20% reduction, relative risk reduction. In ticagrelor, however, there was no increase in major bleeding. This is important to note. Although there was increase in non-CABG related bleeding, but there was no increase in major bleeding. Therefore, ticagrelor gives an opportunity of balanced ischemic protection and bleeding endpoint reduction. Different trials, if you compare from clopidogrel to prasugrel to ticagrelor is the only drug which showed decrease in CV mortality. All other drugs, they did not show decrease in CV mortality. Their primary endpoint reduction was majorly driven by reduction of peri-procedural MI, and therefore it was shown to be beneficial. Whereas in ticagrelor case, in Plato, ticagrelor showed CV endpoint reduction, CV mortality reduction. Now, knowing all these drugs, the doses, as you know, most of you must be familiar, so I can skip this. Aspirin is standard dose is 150 to 300. Only point I want to add is that in American patients, American guidelines, you will see the doses of 162 to 325 because the lowest dose is 81 milligram available there. Whereas in Europe and this part of the world, the lowest dose is 75. So in that multiple aspirin dose you will see. Now another point I want to just highlight is, in case of prasugrel, the loading dose is 60 mg followed by maintenance dose is 10 mg. However, in patients of less than 60 kg body weight and patients who are elderly more than 75 years, maintenance dose of 5 milligram daily is recommended. Ticagrelor already I have discussed, loading is 180 and maintenance is 90 milligram BID. This is the last one, just I want to highlight here is called Cangrelor. This is the latest antiplatelet which is available in the IV intravenous form. It is given in a bolus of 30 microgram kg followed by 4 microgram kg infusion for at least 2 hours for the duration of the procedure, or if the procedure ends up before, then you can continue after that also. One thing I want to add here is that if you want to administer the oral antiplatelet on a patients who you have done PCI on Cangrelor, you can give these oral antiplatelets while Cangrelor is in infusion, so that you don't have a gap of Cangrelor stopping and these drugs taking their action, because there is always a lag period of some minutes to hours depending upon which antiplatelet you are using to start their action. For example, if a patient is on Cangrelor infusion and you stop immediately, its action stops. And if you don't give the oral antiplatelet before stopping, then the duration of action of the oral antiplatelet may take some time. So patient may be exposed to ischemic risk. So that is the point to note. GP2B3 agents are, in past we used to use more commonly in peri-procedural patients, both even in medically managed patients also we are using. But nowadays, with the advent of stronger antiplatelets like Ticagrelor, Prasugrel, we are no more using as a routine. Earlier we used to use upstream situations. Nowadays we are using only as a bailout whenever during the procedure there is any thrombus or any situation like that. As a bailout only we are using, that too only during the procedure, and we don't use infusion anymore. Now, how do you choose different antiplatelets in different situations of acute coronary syndrome? We know that different antiplatelets gives you lots of opportunities in terms of their profile, but also they give you lots of challenges. Some antiplatelets are slow acting, but their bleeding risk is less. Some antiplatelets are fast acting, but they give you more bleeding risk. So how do you choose? Before that, I want to show you the current recommendation by European guidelines that was published recently in 2023 December. The guidelines show that dual antiplatelet of including an aspirin and a P2Y12 receptor inhibitor should be given for 12 months. This is the standard recommendation. And after 12 months, you stop the dual antiplatelet, that is aspirin component, continue with the stop the P2Y12 component and continue with the aspirin. That is the standard recommendation for most of the patients. However, some patients, because of their different clinical scenarios, you will need an alternative guidelines, that is abbreviated dual antiplatelet therapy for particularly patients who have high bleeding risk. Some patients, because of their clinical profile, have high bleeding risk. Therefore, you need dual antiplatelet therapy for shorter duration in these patients. Therefore, these guidelines give us a tool to be used as an abbreviated DAPT. So the recommendation is you stop the P2Y12 component or the aspirin component after 1 month in high-risk bleeding patients. In HBR or higher bleeding risk or non-HBR patients, you can still stop dual antiplatelet, either aspirin or P2Y12 component, even after 3 months to 6 months, depending upon the ischemic burden of that patient. I will come to that later, how to choose abbreviated versus standard recommendation, standard duration of dual antiplatelet. But remember that we have recommendation for standard duration, we have recommendation for abbreviated duration, and also both American and European guidelines give us a class 2B recommendation to extend the duration of dual antiplatelet therapy for certain group of patients, particularly if the bleeding risk is low and thrombotic risk is high. Now, how to come to the conclusion which recommendation or which duration or which composition to be chosen for a select patients? Now, this is at the heart of the decision making. Antiplatelet choice is always a trade-off between bleeding and ischemic risk. An individual's bleeding and ischemic risk needs to be assessed before you can decide whether which composition, which antiplatelet composition you should use, how much duration you should use in these patients depending upon their ischemic and risk, bleeding risk. So we are moving from generalized one-size-fits-all approach to individualized approach where individual risk needs to be assessed. Now, how do you assess the individual risk? Both bleeding and ischemic risk can be assessed from subjectively or objectively from their clinical variables and procedural features. For instance, a patient who presents to you who gives history of major bleeding, anemia, reduced platelet count, prior history of stroke, patient on anticoagulation, recent surgery, malignancy, these are patients carry higher bleeding risk. So while we are taking patients for PCI and procedure, we keep that in mind while choosing the dual antiplatelet therapy. Similarly, procedural features like non-radial access, as Dr. Amer mentioned, femoral access is very prone to develop hematomas and complications, bleeding complications. Then any use of periprocedural GPI infusions or any use of thrombolytic therapy in such patients exposes them to high risk of bleeding. And this risks can be combined in a form of scores which can give us an idea of the bleeding risk of these patients. Accordingly, we can categorize them into HBR or non-HBR group of patients. Now coming to the ischemic risk, how do you define and quantify the ischemic risk? Same, clinical variables and procedural characteristics will give us an idea about their ischemic risk. For example, a patient presenting with acute coronary syndrome, patient with chronic kidney disease, patient with high BMI, polyvascular atherosclerotic disease, these are the patients who have high burden of ischemia. Procedural features like patient undergoing multivessel disease, the long lesion, multiple stent implanted, total stent length being more than 60 millimeter, more than 3 stents implanted, left main intervention, CTO, bifurcation with 2 stents, all these patients carry high ischemic burden. Therefore, they need higher and stronger antiplatelet protection for their optimal outcomes. Then again, objectively also you can combine these risks into scores and they can give you an objective idea about what should be the ideal antiplatelet combination and duration for these patients. Now, when we are taking these patients for PCI, they offer us different sets of challenges in terms of increasing the ischemic risk. Acute coronary syndrome itself is a high ischemic burden situations. Whereas if such patients are taken for PCI, we are going to solve one problem, but also it offers certain challenges. For example, during acute coronary syndrome intervention, there is chance of plaque rupture, there is chance of thrombus embolization, there is iatrogenic vessel injury, which is either micro or major form, and stent itself is a thrombogenic milieu. So that should be kept in mind while selecting antiplatelet therapy. Now, one concept that is emerging and that is in the mind of current interventionalists, you need to keep this in mind, is that the ischemic burden risk is temporary, that is highest during the procedure and it weans off by 1 month and gradually it's tapered off. However, the bleeding risk after initial decline from its highest point during the procedure to it remains stable and it remains high. So in the initial phase of peri-procedural antiplatelet selection, our aim is to reduce the ischemic burden. However, as we go forward, then after 1 month, after 3 months, it is the bleeding risk avoidance that plays in our mind, where we downgrade or de-escalate the antiplatelet therapy. That is how we, choose antiplatelet choice in different situations. This is one of my simplistic approach, how I combine the ischemic and bleeding risk. If I combine the ischemic bleeding risk, I put these patients into 4 categories. One is the L and L, low thrombotic and low bleeding risk, and H and L, high thrombotic and low bleeding risk, then L and H, that is low thrombotic and high bleeding risk, and HBR and high thrombotic risk is the last but least common group. So a patient who has low thrombotic risk and low bleeding risk, my choice is very easy. I will go for standard dual antiplatelet therapy duration, or I can also go for short duration of dual antiplatelet therapy. The rationale is, in low thrombotic risk patients, low bleeding risk patients, I can afford to go for longer duration of antiplatelet, because trials have proven that if I extend the duration of antiplatelet, that reduces the composite of primary events. However, in certain patients where the thrombotic risk is less, single stent implanted, young patient, no comorbids. I have done only 12 millimeter dual current generation stent implanted in the mid LAD. Then in such patients, I can also afford to reduce the dual antiplatelet duration because there is low thrombotic risk. Now let us discuss about the high thrombotic and low bleeding risk patients. Patients where young patient, no major comorbids, I have implanted 2 or 3 stents. They carry high thrombotic risk, but because of their clinical profile, they carry low bleeding risk. Such patients, I can extend the duration of dual antiplatelet therapy, and this is the answer to some of my non-interventional colleagues who keep on asking sometimes that the standard recommendation is 12 months. Why do you people give dual antiplatelet for 2 years or 3 years altogether without stopping? This is the answer. The answer is the interventional cardiologist who has done the procedure, he knows the details. As I said, it is not the one size fits all strategy. We have to individualize also depending upon patient's procedural characteristics. Now, next group of patients is low thrombotic and high bleeding risk patients, where the thrombotic risk is low and bleeding risk is high. Therefore, my choice will be short as possible duration of dual antiplatelet therapy. And this is another reason why I can afford to do such exercise. One is, with improvement in modern generation of stents, the thrombotic risk of such stents have declined drastically. And with advent of modern, newer, fast-acting, safe P2Y12 inhibitors, I can afford to shorten the duration of dual antiplatelet therapy. So that is the rationale behind all this. Now, people who have high thrombotic and high bleeding risk, they are the trickiest kind of patients, where you have to take into account all factors, where which one among them is the most important for you. Accordingly, you can be creative in terms of choice of dual antiplatelet therapy. Now, what are the strategies you should keep in mind while you are choosing the antiplatelet strategy? Now, if thrombotic risk is in your mind, keeping in mind patient profile characteristics, or keeping in mind procedural characteristics such as long stent, bifurcation, and all that, the strategies are, you can go for stronger P2Y12 inhibitors in the form of prasugrel or ticagrelor. You can extend the duration of dual antiplatelet therapy to more than 12 months, that is standard, or you can go for guided escalation. I will come to that later. Now, if bleeding risk is in your mind, not the thrombotic risk. You know that patient has, patient is being managed with medically without any stents, or patient who has characteristics, features of high bleeding risk, anticoagulant, anemia, frail looking patient. Such patients carry high risk of bleeding. In such patients, the strategy is to shorten the duration of DAPT, or even go for monotherapy. One emerging concept is emerging, Dr. Amer would agree to it, that people are going for ticagrelor monotherapy from the start itself, or from after 1 week also. So that is also emerging. That is because of the availability of these good quality drugs. Now another concept is de-escalation. De-escalation means you switch from stronger antiplatelet to weaker antiplatelet. For example, you can switch from prasugrel to clopidogrel or ticagrelor to clopidogrel after certain period. Say after 1 month where the thrombotic risk have declined, I want to go for de-escalation. I want to switch from ticagrelor and prasugrel to clopidogrel to reduce the ischemic bleeding risk, keeping in mind my ischemic burden is not too much. Now these are a group of several trials which is ongoing and completed, and few more slides, which is ongoing, and some of them are completed. They are addressing different, different scenarios, keeping in mind some of them are for bleeding avoidance, some of them are for ischemic risk avoidance. So the idea is, now we have different tools to be used in terms of antiplatelet usage, different tools to be used in different category of patients. It is not one size fits all anymore. 2 risk scores are commonly used, which can help us deciding for whether to continue for short or standard or prolonged duration DAPT. First score is called precise DAPT, that takes into account hemoglobin, WBC count, age, creatinine clearance, and prior bleeding risk. And taking this into account, we, if the score is more than 25, then we decide for short DAPT. This is done at the outset of doing the PCI in an acute coronary syndrome patients. And if the score is less than 25, these patients carry lesser bleeding risk, so I can go for a standard or even prolonged duration of DAPT. At the end of stipulated duration, say after 12 months, I can do a DAPT score again to assess if there is high ischemic burden in such patients, and I can decide for prolongation of dual antiplatelet therapy. That is, if the score is 2 to 10 points, if the maximum score is up to 10 points, the score is more than 2, I can go for long DAPT. If the score is less than 2, I can go for standard DAPT. So that is how we select objectively patients for standard or short DAPT. This is another area, this is the current focus of many of the trials, that is bleeding avoidance strategy. Because with time, over time, what has happened is the stents have become safer, they are thin struts, they are polymer free, all these features, and also there is emergence of stent free strategy, where we are doing certain lesions, we are doing only drug-coated balloon angioplasty without implanting the stent. With the emergence of such strategy, it has become important. So current focus is bleeding avoidance strategy, where the strategies like P2Y12 monotherapy or very short duration of DAPT followed by P2Y12 monotherapy that are being tested, and they have shown to be successful. So trials like Twilight, Ultimate DAPT, and Global Leaders Top DAPT, these are the current group of trials which are focused on this strategy, and that is going to be the future where only P2Y12 monotherapy with ticagrelor will be the practice if it is adopted by the guidelines. Now, ultimately, this is one area which is challenging for everyone that I want to discuss, is patients on anticoagulation. What do you do? Dr. Amer already explained that, you can afford to start patients from the day one, start with monotherapy with dual antiplatelet therapy. But if the ischemic risk is higher, you can give very short duration of dual antiplatelet therapy, that is called triple antithrombotic therapy, for a week, and for a week, followed by you can stop one of the dual antiplatelet therapy, that is aspirin is stopped, and you can continue with dual pathway inhibitors, including a P2Y12 inhibitor and anticoagulant for up to 12 months, and after which you can continue with the oral anticoagulant alone. Alternatively, as a class 2A recommendation, class 2B recommendation, you can switch to dual pathway inhibitor after 6 months also. Now, in patients, sometimes patients will present, and we tend to think whether to load these patients or not. So what is the recommendation about pre-treatment? Should we load all patients with dual antiplatelet therapy at the outset? For STEMI, yes, always load. For non-STEMI, the recommendation is if the duration of, anticipated duration of invasive management is less than 24 hours, you can afford to hold the loading dose of at least P2Y12 inhibitor agent till the angiographically anatomy is defined, because some of these patients may go for surgery, CABG, and if you have loaded with a P2Y12 inhibitor, then it becomes challenging to manage such patients. That is only in case of non-STEMI. However, with current generation of interventionalists, with current techniques, mostly we can deal with these patients with PCI alone. Therefore, most of our patients, we try to load them rather than avoiding loading. However, if you are trying to manage these patients with medical management, you should load these patients with both aspirin and P2Y12 inhibitor always. So to conclude, antiplatelets play an important role in the management of acute coronary syndrome. Aspirin remains the oldest and commonest prescribed antiplatelet agent. Addition of second agent in the form of P2Y12 inhibitor significantly improves the outcome, as shown in different trials. Individual agents have unique safety and efficacy profiles, which give us opportunity as well as challenges. We can make use of these properties in different clinical scenarios to have an optimal outcome in our patients. Thank you very much.
Thank you, Dr. for this condensed and very rich session. We really have much questions about that, but unfortunately we have to skip the question session and go for the next speaker, because we have to stick to the time frame of the program.
Thank you.
Thank you so much.
Thank you, Doctor, for that very informative and extensive presentation. Now, moving on to our third and last speaker. He will be covering the topic on combination therapy in treating dyslipidemia in acute coronary syndrome patients. He is an interventional cardiologist with an extensive experience in the field. He did his DNB in cardiology from prestigious Apollo hospitals in Hyderabad, India, and went on to complete a fellowship in interventional cardiology at the same institute. He is a life member of the Cardiological Society of India and has multiple publications in national and international journals. He is currently the director of the Cardiac Cath Lab and consultant cardiologist at BSH Apollo Heart Center, Bahrain. Please help me welcome our third speaker, Dr. Abdul Azeez Asad Mohammed.
Good evening, ladies and gentlemen. And first of all, thank you all for being here on a weekday and an impressive audience today. Always difficult being the last player on the field. and I'm the only one who's keeping you from dinner, so I'll try to keep it short. Now, I'm dealing with combination anti-hyperlipidemic therapy in patients with dyslipidemia and who've had an ACS. Now, we've discussed anticoagulation, that is more important in the acute phase, like Dr. Amer said. Antiplatelets, probably more important for about a year, and then statins or combination lipidemic therapy for the rest of the life. So this is what we're going to do with. So, brief overview. We'll discuss the role of cholesterol in acute coronary syndromes and benefits in reducing the same. We will discuss the complementary roles of inhibiting cholesterol as well, absorption as well as inhibiting synthesis in the management of hyperlipidemia. We will have a brief discussion about some of the cardiovascular outcome trials in this regard, and we'll discuss some of the guidelines. Now, acute coronary syndromes, what we see as an acute plaque rupture is just the tip of the iceberg. What is happening underneath is many things. There are multiple coronary plaques, there is persistent hyperactive platelets, there is vascular inflammation, and all of this needs to be dealt with. Now, the concept of cholesterol, the LDL cholesterol as a major risk factor, was known to us for almost 2 to 3 decades now. And we also know that lowering LDL cholesterol goals after ACS leads to a significant reduction in recurrent events. And what is the data for this? So the earliest data came from this Swedish registry. So where it showed patients who had an ACS, and they estimated the mortality after 1 year. And what they found is that statins reduced there was a relative risk reduction of about 34%, and revascularization about 36%. And when you combine both, when you revascularize the patients and then put them on statins, the reduction was almost 64%. Now, the pathophysiology, the other speakers have discussed. So there is basically thrombus formation, there is activation of the clotting system, there is platelet adhesion activation, plaque rupture, cholesterol inflammation, all these things we've already discussed. So we'll be talking about how to reduce those outcomes. Now, statins, we've known for almost 2-3 decades now. The initial trials showed whether it was primary prevention or patients with high risk atherosclerotic cardiovascular disease risk or secondary prevention, the statins reduced the risk of events by about 25 to 30% in most of these trials. And this was an early trial wherein the survival rates were measured on patients who had an ACS and who were given lipid-lowering agents versus no lipid-lowering agents. And probably this would be an unethical trial now, but this is long back. So there was a large difference in survival within about 180 days. So within 6 months, you saw that the survival with lipid-lowering agents, particularly statins, was there in comparison to patients who had no lipid-lowering agents. And also, what happens if patients discontinue the medicines? When patients are admitted in the hospital, you load him with statins and then you discharge him and they discontinue the medicines, there is a greater chance of event occurrence if the patients discontinue the statins. Now, we all also have been loading the patients with statins at the time of acute MI or at the time of PCI, we've been loading the patients. So where does this data come from? So it was from the Prove It trial, which was very early. What they did was measured pravastatin regular dose with atorvastatin high dose. And what was found was that the rate of death as well as major cardiovascular events, it was definitely lower in patients who were given high dose of atorvastatin. And this was confirmed in the Prove It TIMI-22 trial where these patients were followed up for 2 years. And then the relative reduction in cardiovascular disease on patients from moderate intensity statins to higher intensity statins was almost 16%. And so is it only statins that we know? There are other therapies as well. So as you can see, there are other therapies that have been in use. Bile acid sequestrants, very rarely used now, probably in pregnancy or other states where statins are contraindicated. They decrease the total cholesterol, they reduce the LDL cholesterol, they increase the HDL just a little bit, and triglycerides, they are neutral. Then niacin or nicotinic acid, It decreases the total cholesterol, decreases the LDL, and increases the HDL. This is one of the therapies which increases the HDL, but unfortunately, it is not very well tolerated. Fibrates are used nowadays, but less commonly. So they decrease the LDL cholesterol, increase the HDL cholesterol, and decrease the triglyceride levels. Propicol is not used anymore. Statins, as we know, they have a beneficial effect on the total cholesterol, on the LDL cholesterol. HDL doesn't make much of a difference, may increase it a little bit. Triglycerides, there is about a 14 to 20% reduction with statins. And ezetimibe, it decreases the LDL, not much action on the HDL, and it can decrease the triglycerides as well, and these are well tolerated. Now, so when do you want to give these medicines, and how do we combine these medicines? So for this, you need to understand what is the concept of residual risk. So as I showed in the trials earlier, statins, they reduced the risk of events by about 25 to 30%. So there is still a large risk that is remaining. So there is still a large risk. Something's wrong here. Okay, I cannot see the slides here, but here they are available. So there is still a large risk remaining that is not treated with statins alone. And if you increase the dose from a higher dose statin to even higher, so the absolute risk of CV events was reduced by only about 1%. So then, sorry, there's a technical issue here. It's trying to connect from the laptop. Sajid, can you play the slides from your end? Yeah? Was I going too fast? All right. So then came the IMPROVE-IT trial. So this was one of the larger trials which showed a reduction in outcomes when we added something onto statins. So what was the medicine added? Ezetimibe plus simvastatin compared with simvastatin alone in patients who were high risk and who were presenting with an acute coronary syndrome. Next slide, please. Nope. All right. So this was a large trial over about 7 years, and what was seen is cardiovascular death, MI, unstable angina, coronary revascularization within 30 days, or stroke. These were studied in 2 groups. So patients requiring taking simvastatin alone versus patients taking simvastatin plus ezetimibe. And as you can see, there was a modest improvement in the outcome results. Next, please. Yes, so this were these pre-specified secondary outcomes. So the primary was cardiovascular death plus MI plus unstable angina or coronary revascularization or CVA. Secondary outcomes included all-cause death, MI, unstable angina. Or, as you can see in the slides, there was again ezetimibe plus simvastatin was a little better compared to simvastatin alone. Next slide. Yeah, so here also again showing the similar things. When the all-cause death did not change much, cardiovascular death did not change much in these 2 groups, But the risk of MI, the risk of stroke, the risk of ischemic stroke, and the incidence of coronary revascularization, these were better in the patients receiving ezetimibe along with a statin. Next, please. Oh, yeah. And when it came to side effects, not much difference in side effects. The most common side effects was either related to the liver or gallbladder. So asymptomatic increase in ALT or AST or cholelithiasis were the side effects, which is common in both the groups. So basically this trial showed that non-statin lowering LDL cholesterol will, with ezetimibe, reduces cardiovascular events, and even lower is better. So patients who achieved mean LDL cholesterol 53 versus 70 milligrams at 1 year, they did much better. And non-statin lowering cholesterol with ezetimibe, it reduced CV events and reaffirms the LDL hypothesis. Now what about triglycerides? A lot of time patients come to us saying, my triglycerides are high, is it important, what needs to be done? So the normal triglycerides we accept around less than 150 milligrams per deciliter. So 150 to 200 is borderline high, 200 to 500 is even higher, more than 500 is very high. So now I was talking about the remnant cholesterol or the residual risk. So similarly, remnant cholesterol is when you take off the LDL cholesterol, whatever is remaining, and how that is related to MI. So what we see is the incidence of MI goes up with the increasing levels of remnant cholesterol. And a majority of the remnant cholesterol is nothing but triglycerides. And there has been found to be an increased risk of premature familial CAD in patients who have elevated plasma triglycerides. And this risk starts not at 500 but even at 200 milligram per deciliter. And so treating these triglyceride levels, so how do we treat? One of the most common used medicines is fenofibrates. So a statin with fenofibrate, when we studied in the Accord trial, about 5 years of treatment, and then what was seen was there was a risk reduction in patients with dyslipidemia and type 2 diabetes mellitus. The event rates decreased by about 27% when a fenofibrate was added to a statin. This was another trial about GISI trial. This is the independent and combined effect of fatty acids along with vitamin E. So this also was patients who were basically patients with ACS, and these were the primary endpoints: all-cause mortality, non-fatal MI, non-fatal stroke. And what was found was within 3 months of acute event, when these patients were given N3-ethyl ester compared with control, there was a marginal benefit in these patients. And the other therapies were already in place. The antiplatelets were already in place. The ACE inhibitors and beta blockers were already in place. So with these therapy, they showed there a slight increase in survival rates. Now coming to these patients who the mean days since diagnosis was about 25 days. The mean age was about 60 years. And based on these, so these patients, we see the LDL cholesterol was on the higher side and the triglycerides was 162, which is fairly okay. 150 is the target, 162 was fairly okay. So these patients, despite being on this, they did better. And the incidence of non-fatal MI or stroke, non-fatal and overall mortality was lesser in the group receiving the fatty acids. Now coming to an important slide here, the PCSK9 inhibitors. These have been available for about a decade or so now. And basically, PCSK9 is pro-protein convertase sublithium type 9, very difficult to pronounce that one. It regulates the cell surface receptors, in particular the LDL receptors. And by inhibiting these enzymes, you are causing decreased uptake of the LDL. And these are basically monoclonal antibodies, and they target and inactivate these PCSK9, and this is basically happening in the liver. And the effect is a dramatic decrease in LDL cholesterol. So the two molecules that are available is avelumab and alirocumab. Avelumab is available in Bahrain as Repatha, and avelumab we still don't have it. So these were the trials that were done, and it showed significant reduction in LDL cholesterol. Almost about 50% reduction was seen. And when it comes to early PCSK9 inhibitors in ACS, so the advantages are you not only reducing the lipid levels, you are reducing the potential for inflammation and potential for plaque regression as well as event risk prevention. Yeah, this was a trial of the Odyssey outcomes where they studied aliricumab and CV outcomes in patients with ACS. And about 18,000 patients who were already on maximally tolerated statin therapy who had an ACS within the last 12 months. And so the goal of the trial was to get down the LDL to between 25 and 50 milligrams per deciliter. And after a median follow-up of 2.8 years, so what we found was the LDL in the PCSK9 group was about 53 compared with 100 in the placebo arm. These patients are already receiving high-dose statins. The incidence of adverse events were same except for the local injection site reactions. But if you look at the event data, the mean LDL cholesterol came down from 103 with the placebo group to about 53 with aliricumab. And if you can see this slide, I'm not sure if it's visible to you. So it showed a reduced composite primary endpoint, that is coronary heart disease death, non-fatal MI, unstable angina or ischemic stroke. There was also a reduction in all-cause mortality, and these reductions were more marked if the patients had a baseline LDL of more than 100. So the current recommendations for PCSK9 inhibitors are, of course, familial hypercholesterolemias and patients with ACS who are on a maximally tolerated statins and still their LDL is not reached to the target. This is another molecule similar to PCSK9. It's called inclisiran. This is also available in Bahrain. It's called Legview. The dosage is much better. Evolocumab needs to be given once or twice a month. This can be given once in 6 months. So what we found was this is basically a messenger RNA and that interferes with the target PCSK9. Multiple trials have demonstrated efficacy of this, and in patients with prior MI, the mean reduction in patients who were receiving inclisiran was about 52% in patients who had a recent MI. And it was well tolerated. Now, another molecule which is making a lot of waves is bempedoic acid. This was present in the last year ACC, I think. It is similar to the statins. The statins act on the HMG-CoA, as we all know, and bempedoic acid acts 2 steps above that. So conversion of citrate to acetyl-CoA is done by the ATP citrate lyase enzyme, and this molecule acts on that. So the advantage of this bempedoic acid is that there is definite LDL reduction, but the side effects are lesser. Particularly patients who do not tolerate because of myopathies, muscle problems, bempedoic acid is a wonderful addition to our armamentarium. Okay, so did I skip something? Okay, so what do the guidelines recommend? So if you look at the recent guidelines, so these are the 2019 guidelines. So all patients with an ACS, definitely they should be initiated and should continue high-dose statins. So high-dose statins, we mean the target is to bring down the LDL by 50%. So this is achieved with rosuvastatin 20 to 40 milligrams or atorvastatin 40 to 80 milligrams. That's the standard. Now, you should also reassess lipid levels at about 4 to 6 weeks after an ACS to determine if there is a 50% reduction from baseline or not. And if this is not achieved, then you can add a second combination with ezetimibe. And again, these guidelines also routine pre-treatment or loading is required. Supposing patient was on atorvastatin 10 milligrams or 20 milligrams, come to you with an ACS, you have to load these patients again. You give them 80 milligrams again, or even if it's an elective PCI. All right. And what about elderly people? In patients who are 75 years or more, you can initiate these patients on high-dose statins, but of course you have to monitor for side effects more commonly in these patients if it is for secondary prevention. I'll skip this slide. Let's go. All right. So the effect of the various drugs on the LDL cholesterol. So we should. This is probably the last but one slide. So if you give a moderate intensity statin to a patient with ACS, the reduction in LDL cholesterol is about 30%. If you give a high intensity statin, like 80 milligrams of rosuvastatin or rosuvastatin 40 milligrams, you have a 50% reduction in LDL cholesterol. And if you add ezetimibe to high dose intensity, the reduction is about 65%. And if you give the patient only PCSK9, it's about 60%. And PCSK9 plus a high intensity statin, the reduction is about 85%. You probably actually have to worry whether these patients are going below the normal levels or not. I think about 15 to 20 is kept as the target, and don't go below that. So a take-home message, we all know that hyperlipidemia is one of the basic causes of acute coronary syndromes, and treating this becomes an integral part of the management of patients. Statins remain the cornerstone of treatment, and in patients who are statin intolerant or who are not able to reduce or to achieve their goals, so newer options are available, and they must be considered in these patients. Thank you all.
Thank you so much for that very interesting discussion. Now, as we come to the close of today's CME's event, I would like to invite Mr. Mahmoud Ardati, our Chief Operating Officer of BSH Hospital, to deliver the vote of thanks. Let's give him a warm welcome of applause.
Assalamu alaikum, good evening everybody. My brother was just telling me that, as a non-medical person, attending these sessions might be very painful, but to be honest, I kind of enjoy them, even though most of the material is right over my head, it's still very interesting to, look at the depth of, a doctor when they come into their practice. It's not a static thing, things are developing all the time. New approaches, new treatments, new medicines, new trials, and like I said, even though most of this is complete gibberish to me, it's very, enheartening and very, encouraging to see that so many of you are interested in keeping up to date, knowing what's going on, how it's going to affect your patients and your care. And for giving us the opportunity to share this evening with you, I'd really like to thank your attendance, and I will stop talking so everybody can go have dinner. Thank you very much, everybody. Ya'ataykum al-afiyah.
Thank you, Mr. Majid. And once again, thank you all for attending today's event. We hope you found the session informative and beneficial. A special thank you as well to our sponsors for their generous support. Please be sure to visit their booth at the corner of the hall to learn more about their products and services. And once also, I want to remind you that before you leave, to fill up the evaluation form for your CME points. And last and final request, we would like to have a group photo, please. So one group photo with our speakers, panelists, chairperson, distinguished guests, and the other group photo with all the participants. And then we can all have a nice dinner. Thank you very much.